Hello again, and welcome to Neutralizing COVID, the monoclonal antibody story, the podcast where we unpack the science, strategy, and real world impact of monoclonal antibodies in the fight against COVID 19. I'm your host, Dr. Shikha Agrawal. In this episode, we are tackling a safety concern that sparked plenty of debate: antibody dependent enhancement, a concern with COVID monoclonal antibodies. Is it something to worry about when using monoclonal antibodies for COVID 19? Or has the science moved us past that concern? To help us break this down, welcoming back the ever insightful Dr. Aiswarya Chaudhuri, a nanomedicine specialist. Thanks for joining us, Dr. Aiswarya.
Thanks for having me, Dr. Shikha. This is an important and most misunderstood topic, so I'm glad we are talking about it.
Let's start with the basics. What exactly is antibody dependent enhancement?
ADE, or the antibody-dependent enhancement, happens when antibodies, instead of neutralizing a virus, actually help in entering the cells more efficiently or trigger harmful immune responses. It's most famously associated with viruses like dengue, where certain antibodies can worsen disease during a second infection. Essentially, it's a situation where the immune response or a therapeutic antibody unintentionally enhances the infection rather than stopping it.
So, how does that apply to COVID 19 and monoclonal antibodies?
That was a major concern early in the pandemic. Now, since SARS-CoV-2 is a coronavirus and ADE has been observed in other viral infections, researchers were cautious. The worry was that antibodies generated from infection, vaccination, or therapy could potentially make things worse by helping the virus infect immune cells or by causing excessive inflammation. However, what we have seen across vaccine studies, monoclonal antibodies, and real world use is no evidence that AD is a clinical issue with the SARS-CoV-2. So far, the monoclonal antibodies developed for COVID-19 have shown to be either neutralizing or ineffective, but not enhancing infection.
Excellently explained. What makes the SARS-CoV-2 different in that regard? Why hasn't ADE emerged?
There are a few reasons. Firstly, SARS-CoV-2 primarily infects cells using the ACE receptor, which is not present on most immune cells. The typical targets for the ADE-related infection. That limits the virus's ability to exploit the antibodies to get into the wrong kind of cells. And secondly, the monoclonal antibody used for the COVID-19 has been specifically designed to be highly neutralizing. They bind tight into the spike protein and block its interaction with the ACE2 receptor. That high affinity and precise targeting reduce the chance that the antibodies could help the virus instead of stopping it.
So, are there any situations where ADE could still be a risk with COVID 19 treatment?
Theoretical risk always exists, especially when antibodies are only partially neutralizing or when the virus is mutates. If a variant emerges that partially escapes the neutralization, the antibodies still bind but don't block infection. It could, in theory, contribute to ADE. That's why antibody therapies are carefully screened not only for neutralizing but also for the interaction with the FC receptors, the part of the immune system that might contribute to the ADE-like responses. Some receptors have modified FC regions to reduce the potential for unwanted immune activation.
That brings up a good point. What role do FC regions play in ADE?
The FC region of an antibody is the part that interacts with the immune cells. So in ADE, the problem can arise when these regions help the virus enter the immune cells to the FC receptors. For COVID-19 monoclonal antibodies, developers can engineer the FC region to minimize that kind of interaction. For example, by reducing binding to FC gamma receptors. This reduces the risk of antibody-mediated immune activation or viral entry into inappropriate cells.
So, from a scientific standpoint, is ADE still on the radar in COVID-19 antibody development?
Yes, it's something researchers continue to monitor. Every new variant, every new antibody combination, every vaccine is screened for the possibility of the ADE in preclinical studies. But at this point, with the data we have, ADE has not been a problem with any of the authorized monoclonal antibody treatment for the COVID-19. That's reassuring. It means the design and the safety testing have worked.
Just to be clear for listeners, this doesn't mean ADE is imaginary, right? It's just that it hasn't shown up with COVID-19.
Correct. AD is a real biological phenomenon. It has been observed in other viral infections, but for COVID-19, despite all the close attention and the massive scale of treatment and vaccination, there's no clinical signal that monoclonal antibodies can cause the ADE in patients.
Before we wrap up, what's the main takeaway when it comes to ADE and monoclonal antibodies for COVID?
The takeaway is that ADE was a valid concern early on, and it's still carefully evaluating all antibody development. But so far, the science and safety data have shown that the monoclonal antibodies for COVID-19 have not triggered the ADE. Advances in antibody engineering combined with our understanding of the SARS-CoV-2 biology have helped keep that risk in check.
This conversation was packed with insights our listeners can take away. Thank you, Dr. Aishwarya, for helping us understand the science and safety behind these therapies. It's reassuring to hear how carefully these risks are being studied.
Absolutely. Thanks for having me, Dr. Shikha.
That wraps up this episode of Neutralizing COVID, the monoclonal antibody story. To our listeners, thanks for being here. Remember to hit follow and share this conversation with someone who would over to it. Until next time, take care and keep exploring science.